Hello everybody, my name's Justine Tomlinson and I'm a pharmacist by background. I conducted this research as part of my PhD, which was then analysed further as part of a final year student project at the University of Bradford. I'm presenting on behalf of our co-authors, of which I'd like to take this opportunity to thank Peter, Habiba and Hakirat for their analysis work, and Beth, Kate, John and Heather for their supervisory support. Our research is funded by a Research for Patient Benefit grant from the NIHR, and I'm very pleased to share with you the findings of our work. My area of interest is medicines safety for older people after they've returned home from a hospital admission, often with multiple medicines changes. This current project aims to explore the lived experience of this and to develop some tools that will help older people with their medicines management after hospital discharge. In this presentation, I'm going to focus on some pathway mapping work that we conducted as part of our patient experience work. But first, let me tell you a little bit about the topic. There are numerous threats to medication safety after hospital discharge, which are heightened for older people because they live with multiple long-term conditions, as well as polypharmacy, and have frequent hospital admissions. We know from the literature that 1 in 3 older people will experience some form of harm from their medicines within 8 weeks after discharge. This is really distressing for the patient, also frustrating for their families and costly to the health system. Evidence suggests that this costs approximately £400 million every year. Now, whilst there's evidence of the severity and scale of these medicines-related problems, there's really insufficient detail about the lived experience of post-discharge medicines management, and in particular, the patient journey through and contact with the healthcare system. Now, this project is part of a larger programme of work to co-design solutions to post-discharge medicines-related problems. And as part of the larger study, interviews were held with older patients and their family carers to explore their lived experience of post-discharge medicines management. Now, where the participants consented, of which there were 11, details of medicines-related events during the 6 months post-discharge were collated from primary and secondary care documentation. Key timeframes, types of contact with the healthcare system, and qualitative details relating to post-discharge medicines management were extracted from the records. And the data was synthesised into a journey map for each participant. Now, as I mentioned, we have 11 participants. 3 were men, the mean age was 85 years old, and there was an average of 3.9 medicines changes after hospital discharge. Now, the maps, as you can see an example on the screen here, provided a visual representation of the post-discharge pathway from the system perspective. We compared them, analysed them thematically, as well as using frequency counts to identify the contacts with the system. Phelan et al.'s conceptual resilient healthcare framework of gaps, traps, bridges and props were applied to the thematic evaluation, which allowed us to identify the barriers and facilitators to post-discharge medicines management. We categorised the features that produce discontinuities, the gaps, or things that could result in errors, the traps, informal actions, props, and permanent features that promoted medication safety, bridges, were also identified. Now, the 11 maps were interrogated and they highlighted a significant number of contacts with the healthcare system across both primary and secondary care and in the post-discharge phase. The main contacts were with the patient's community team, for example, the district nurse, and general practice, whilst there were fewer with the hospital, emergency department, NHS 111 service, etc. Numerous potential patient safety incidents were identified, with the majority caused by delayed or incomplete communication, followed next by prescription issues. Other potential medicines-related incidents included falls, prolonged referrals, no or late reviews, and inappropriate prescribing. In a number of cases, medicines review was reported to have been conducted. However, this was often not performed with the patient present. Now, across all the maps, gaps and traps were evident. Examples included miscommunication about medicines changes between settings, medicines discontinuity, confusing discharge documentation, and lack of follow-up review or delays in receiving follow-up information. Sometimes these follow-up reviews did not actually include the patient, and the healthcare professional reviewed the medicines without them being present. Repeat dispensing systems allow patients to reorder double supplies, sometimes of incorrect medicines. Whilst these have potential to cause medicines-related problems, bridges and props were available within the system, such as a self-management service that was tailored to the medicines requirement of the individual patient, development of care plans by general practice pharmacists, and the repeated assessment of medicines management needs by community teams. Patient and carers also reached in to support the system by contacting the relevant professional and informing them of medicines changes, or instructing one organisation, such as the community pharmacy, to ring the GP to ask about the new medicines. Now, in summary, participants' post-discharge pathways showed numerous contacts with various healthcare professionals for medicines-related issues, and potential patient safety incidents were evident. Whilst the healthcare system is equipped with features to promote safe and effective post-discharge medicines management, such as the electronic transfer of discharge documentation, barriers remain which require further investigation and resolution. Communication quality and timeliness continues to be problematic, and primary care needs to consider how valuable it is to conduct medicines reviews without the patient, a matter frequently identified in a number of our data extraction cases. Often decisions were made that should have included the patient, or that the patient could have given more details about, which would have provided a quicker resolution. Thank you so much for listening to our results there. And if you do have any questions or comments, please do get in touch. We'd love to hear from you. Thank you.